Hi friends, so we are very close to the exam now. I thought it would be a prudent step to include perhaps the most important topic for your upcoming exams as close to your exam as possible. And therefore today is our last final stride session and we are going to discuss probably one topic which is the most important for your upcoming exam, and that is going to include chest imaging, that is mainly chest x-rays, right, lung related conditions and some important emergencies. I'm sure and I am hoping and praying that you get at least 1 to 2 questions from this very short 15-minute session that we are going to have here in the next few minutes. So let us start. See here. This was a recent INI pattern exam question. See here, a young male was brought to the ER after road traffic accidents. His respiratory rate is elevated, BP is low. On examination, there is hyperresonance which is heard over the right side of the chest. Chest X-ray is shown below. What would be the management? So they have asked you about the management, right? You must know what the diagnosis is. So what is this image? Look here. If you watch grossly, right, you look at the heart, you look at the right lung field, left lung field. I hope you realize that the right lung field is appearing excessively black, isn't it? What appears black on X-ray? Air, isn't it? But if you look at that black appearance in the right hemithorax, can you see any vascular markings or blood vessels within it? No. If you see excessively black appearing lung field without any vascular markings within it, it suggests what? It suggests that there is air within the pleural cavity. So this is right-sided pneumothorax. Is it just pneumothorax? Let us quickly have a look. See here. So this is what we have discussed. This is hyperlucency. Lucency means what? Lucency means blackness. Hyper means excessive black. So excessively black appearance with absent vascular markings, right? So this is air within the pleural cavity, right? There is a visceral pleural line. See, this is the lung parenchyma, and because the lung is lined by the visceral pleura, this water density of the visceral pleura is now lined by, on its lateral aspect, by air. Differential radiographic density theory creates this sharp line, and this is what is called as the visceral pleural line. Then because there is a lot of air within the hemithorax at a very high pressure, it is going to slightly shift the mediastinum towards the opposite side. Similarly, it is going to push the diaphragm down, so the ipsilateral costophrenic angle sulcus appears very deep. This is what is called as the deep sulcus sign, and there is going to be slight over expansion of the rib cage. As in this patient, you can see mediastinal shift, you can see that there is a deep sulcus sign, slight expansion of the rib cage, right? All these three mass effect features points towards the diagnosis of tension pneumothorax. What is tension pneumothorax? Right, it is a state in which there is a one-way valve mechanism which has developed between the lung and the pleural cavity. So with every breath, air is going to enter into the pleural cavity. Normal intrapleural pressure is negative. As more and more air enters into the pleural cavity, this negative pressure is going to increase. It is going to come to 0, and then after that point, if still more air enters into the pleura, it is going to become positive. Positive intrathoracic pressure is going to compress the lung. Yes, so there will be respiratory compromise. It is going to compress the SVC, IVC, so venous return is blocked, cardiac output is blocked, patient will collapse and die. And therefore, a very favorite question of your examiners is, how do you treat tension pneumothorax? Yes, the first step in the management of tension pneumothorax is called as what? Yes, you know it. It is called as needle thoracotomy. So first step in the management of tension pneumothorax is needle thoracotomy, right? So you put a needle within the thoracic cavity. This needle in adults is put in the 5th intercostal space, slightly anterior to the mid-axillary line, close to the mid-axillary line. Remember, A for adults, A for mid-axillary line, 5th intercostal space. In children, it is put in the 2nd intercostal space at the mid-clavicular line. By putting in a needle in the pleural cavity, you are creating a communication between the pleural cavity and the atmosphere. Remember, intrapleural pressure is at a very high pressure, so this is going to come out, right, until there is equalization of pressures, and that is when the tension component will be relieved. Once the tension component is relieved, what is remaining? Pneumothorax. And what is the treatment for pneumothorax? It is intercostal drain insertion. So it is the second step after the tension component is relieved. It is inserted into the triangle of safety. You know the anatomic landmarks of the triangle of safety. You have studied it in anatomy as well as surgery. So this is about the management of tension pneumothorax. So what is the diagnosis in this case? The diagnosis in this case is tension pneumothorax, and they are asking you what is the best, what would be the appropriate management. Wide bore needle insertion in the 5th intercostal space is yes, but as compared to option A. Option B is better because it says wide bore needle insertion in the 5th intercostal space. This is an adult patient, right? 5th intercostal space, right, in the mid axillary line, followed by an intercostal drain. This is more correct, right? So this is going to be the correct answer here. First step is needle thoracotomy to relieve the tension component. Once you relieve the tension component, the next step is going to be a wide bore intercostal drain insertion. Yes. Now look at this image. This is a very peculiar, very atypical image. Doesn't look like any modality that we can easily recognize. This is in fact, remember, a very classical appearance which is seen on M mode ultrasound image. So this is a M mode USG image which I am showing you. M in M mode, if you remember the rad imagine animations that we have seen, in the marrow module, right? M in M mode stands for motion, right? So this is motion mode or M mode. In normal patients, you see this appearance, it detects motion. So these are the waves of the sea, and these are created by the chest wall layers. Whereas this looks like the sand on the beach, this is created by the lungs. So this is what creates the seashore appearance in normal patients on M mode ultrasound. This was the question which was asked. Now in pneumothorax, what happens is that this appearance changes to something like this. So you get a uniformly striped appearance like a barcode or stratosphere. So this is called as a stratosphere sign or barcode sign, which is seen in pneumothorax. So the question that we just saw was this image. So what is this sign called as? It is called seashore sign. It is seen in normal patients in contrast to the stratosphere sign which is seen in pneumothorax. So look at this question which was again asked once. So a patient of road traffic accident with injury over chest and limbs has low oxygen saturation. Why does the patient has low oxygen saturation? Here is because M mode ultrasound of the right upper part of the chest shows stratosphere sign, and stratosphere sign is seen in what? Stratosphere sign is seen in pneumothorax. That was the answer of this particular question. Yes. Now look at this. This is something that you just cannot afford to miss, this diagnosis. Your examiner is asking you this diagnosis repeatedly every other exam. Why? Because your examiner expects you to make this diagnosis and not miss it. See here, 40-year-old man presents to the ER with severe abdominal pain. Heart rate is elevated, tachycardia, BP is low, guarding is present, erect abdomen X-ray. This is what I want you to see. What is this? This is free air under both domes of diaphragm. So free air under both domes of diaphragm is what it is called as pneumoperitoneum. So this is pneumoperitoneum. In an adult, the most common underlying cause is perforation, perforative peritonitis. So what do you do in this patient? USG abdomen will have no role, right? It will not show you the site of perforation anyways. Air is enemy of ultrasound, so it is going to obscure a lot of images that you would get. IV fluids, yes, because the patient is in hypotension, you must stabilize the patient. IV fluids is correct. And remember, once you see and diagnose pneumoperitoneum, it is because of perforation. You need to do an emergency exploratory laparotomy. Elective surgery is not planned. You cannot postpone the surgery. The patient may go into septic shock and die. Conservative management is also not feasible. So the answer here is going to be A, 2 and 3, that is IV fluids along with emergency exploratory laparotomy. So remember, I want you to be absolutely beware of missing this. You should not afford to miss this, right? You cannot afford to miss this, because if you miss this, not only you will get this MCQ wrong, but that doesn't matter much, but the patient might lose his life. Because a few hour delay in treating this patient, the patient would go into septic shock and you may lose the patient. So whenever you're looking at a chest X-ray or an abdomen X-ray, make it a point that you look at the diaphragm and try to look for this free air under the domes of diaphragm. If you see free air under the dome of diaphragm, you clinch the diagnosis of pneumoperitoneum, perforative peritonitis. The patient has to be operated on an emergency basis, right? So always pay attention to the diaphragm. Try to rule out pneumoperitoneum in each and every X-ray that you see. For minimal pneumoperitoneum, your examiners may ask you the best or most sensitive radiograph is, remember, an erect chest X-ray. In the olden days, left lateral decubitus abdomen was done theoretically, right? They said it was most sensitive, but it is not standardized. It is not commonly done. So what is the most sensitive radiograph or best radiograph? It is erect chest x-ray is better than erect abdomen, remember. So erect chest x-ray is the answer. If they ask you overall what is the best investigation or investigation of choice, it is going to be CT, remember. Now let us discuss a very important concept. This concept will help you get a lot of questions, right, in your exam. Remember always that fluid is friend of ultrasound. So wherever in the body you want to detect fluid, which should be the investigation of choice? It should be ultrasound. So just to name a few, say suppose they ask you investigation of choice for pleural effusion. Effusion means what? Fluid you want to detect. Fluid is friend of ultrasound. USG is investigation of choice. Pericardial effusion. USG of the heart is called echocardiography. That is the investigation of choice. Minimal ascites, right? Again, fluid is friend of ultrasound. Ultrasound is going to be the investigation of choice. So wherever in the body you want to detect fluid, investigation of choice will be ultrasound. Similarly, remember air is enemy of ultrasound. So wherever in the body you want to detect air, ultrasound cannot be used because air is enemy of ultrasound. So wherever ultrasound you are not able to use, the investigation of choice therefore will always be CT. So therefore what we just discussed, what will be the investigation of choice for pneumoperitoneum? It will be CT. Similarly, investigation of choice for pneumothorax will be CT. Though expiratory chest x-ray is considered to be better for detection of pneumothorax, CT is the investigation of choice. Similarly, pneumomediastinum, the investigation of choice will be CT. Fluid is friend of ultrasound, air is enemy of ultrasound is a very interesting anecdote we have discussed in our marrow videos as well. This will help you crack a lot of different questions as you face them in your exams. Most common cause of pneumoperitoneum in adults, remember, is usually bowel perforation. Yes, whereas in neonates, if you see pneumoperitoneum, it is usually necrotizing enterocolitis. So these are the most common causes. Yes, various signs have been described, right? So you see this big oval lucency over the central abdomen. This has been called as the football. This has been called as the football sign. You see a dome-like lucency over the just below the central tendon of diaphragm. This has been called as the cupola sign, right? You see a sharp margin of the liver, that is called liver edge sign. You see a sharp margin of the gallbladder, that is called as a gallbladder edge sign, right? You see a triangular shaped lucency in the region of the Morrison's pouch. This is what is called as the Doge's cap sign. So this is what is called as the Doge's cap sign, right? If you look at a bowel, you are able to see the inner mucosal wall as well as outer serosal wall very well. So this is what is called as the Wriggler's double wall sign. So Wriggler's double wall sign. So these are all various signs which have been described on supine abdomen radiographs in pneumoperitoneum. So what does this classically see here? This is, pseudo pneumoperitoneum. Looks like pneumoperitoneum, but it is not. Why? Because these are all bowel wall markings that you see. This is nothing but a loop of colon which has been trapped between the diaphragm and the right lobe of liver. So it creates an appearance like a pneumoperitoneum, but the mucosal wall folds of the colon, right, tell us that this is not free air, but this is air within the trapped colonic loop. This is called Chilaiditi sign. If this is the only appearance which is seen in the absence of any symptoms, it is called as sign. But along with this sign, if the patient has pain, then it is called as Chilaiditi syndrome. It is a cause of pseudo pneumoperitoneum, remember. Yes. Now look at this chest radiograph. A child presents with high grade fever, cough, elevated total leukocyte count. So probably the child is low respiratory tract infection. Child is on treatment. On 5th day of illness, a chest x-ray is done, that is shown. So see, you can see diffuse consolidation involving the lung, right? But along with consolidations, you can see a round area here. You can see a big round area here. What is this called as? So this is nothing but a cyst. Cyst means seal, right? And it is filled up with what? Air. Air means pneumo or pneumato. So what is this? This is a pneumatocele. So pneumatocele, if you see the case of pneumonia, it is associated with what? It is associated with staphylococcal pneumonia. So pneumatocele is seen in what? It is seen in staphylococcal pneumonias. Now seal out sign, consolidations can be asked in your exams. If there is a consolidation in any part of the lung, it is going to obscure or blur the adjacent soft tissue water density margin of the mediastinum or the heart. So by just looking at an X-ray and seeing what margin is lost or not seen, you will be able to localize the lung infection to a particular lobe. So if you see that if the right upper mediastinal border is obscured, then the disease is usually in the right upper lobe, mostly its anterior segment. If the consolidation is obscuring the right heart border, then the disease is in the right paracardiac area, it is usually the right middle lobe. If the right dome of diaphragm is obscured, then the disease is highly likely to be in the right lower lobe, but it could also sometimes be within the right middle lobe, right? So that is how you localize the infections based on which margin is lost. On the left side, if you see that the aortic knuckle is obscured, then the disease is usually within the apico-posterior segment of the left upper lobe. If the lateral margin of descending thoracic aorta is lost, then the disease is usually in the superior segment or the posterobasal segment of left lower lobe. If you see that the left heart border is obscured, then the disease is in the left paracardiac area, and this is nothing but the lingular segment of left upper lobe. And if you see that the left dome of diaphragm is obscured, then the disease is going to be in the left lower lobe. So this is how you localize the lung infections based on seal out sign. Now as you can see here in this radiograph, there is a haziness in the right paracardiac area, and where the opacity is, you are not able to see the right heart border. So if the right heart border is lost, we just saw the disease is located where? This is right middle lobe consolidation. Whereas look at the second X-ray here, there is an area of haziness in the left paracardiac area, the left heart border is not visualized. If the left heart border is not visualized, the disease lies in the left paracardiac area. Left paracardiac area is what? It is the lingular segment of left upper lobe. So this is lingular segment of left upper lobe. So right middle lobe pneumonia, lingular segment pneumonia, consolidation. Yes. Miliary nodules is another favorite topic. Multiple tiny 1 to 3 mm discrete nodules scattered throughout both lung fields. Most common cause you expect in India is TB, but it is not exclusive or specific to TB. Remember, it can be seen in healed varicella infections, a lot of fungal infections like coccidiomycosis, blastomycosis, cryptococcosis. It can be seen in interstitial lung diseases like coal workers pneumonia, like silicosis. It can be seen in advanced cases of sarcoidosis. It can be seen in chronic mitral stenosis, right? It can be seen in chronic congestive heart failure. It can be seen in miscellaneous conditions like alveolar microlithiasis, right? Some allergic pneumonitis also it can be seen. So these are all the underlying causes, etiological causes of miliary nodules. The nodules throughout the lung fields are said to be distributed in a random distribution on HRCT. So random distributed nodules on HRCT. Right, so randomly distributed nodules on HRCT, right? It is very typical of miliary nodules. Yes. So true regarding CORADS is, what is this CORADS? It is COVID reporting and data system. Specific guidelines which were similar to what you have studied in BIRADS, breast imaging reporting and data system, right? So this was a recently asked question. CORAD 0 is normal, 5 is typical, pleural thickening, COVID can present lobar consolidation. Which of this is true? Let us quickly revise COVID imaging. Question was asked recently, another one could be asked. So HRCT is the overall imaging investigation of choice for COVID. For diagnosis, remember, investigation of choice is RT-PCR. For imaging, the investigation of choice is HRCT. What is the finding that you see on HRCT? It is usually peripheral multifocal ground glass opacity. So you can see these increased densities through which the internal vascular markings are still visible. So they are called ground glass opacities. And what is the distribution of ground glass opacities? They are peripheral, predominantly in the outer 1/3 of the lung parenchyma, and multifocal bilateral ground glass opacities. This is the most common imaging pattern to see in COVID infections. Okay. Now, what is CORADS? COVID reporting and data system. CORADS 1 is when, right? What is the purpose of CORADS? Remember, the purpose of CORADS is to say what is the likelihood of COVID infection. So, likelihood of COVID infection. Remember, there is a CT severity score for COVID, and as the name suggests, it tells you what is the severity. It is a score out of X out of 25. That is how the score is calculated. Each lobe is given a score from 0 to 5, right, and therefore there are 5 lobes, so maximum score becomes 25. So X out of 25 is the score. It tells you severity. CORADS does not tell you severity. What is the purpose of CORADS? It is to determine the likelihood of COVID infection, right? RT-PCR report is not available. You look at a CT scan. By looking at the CT findings, how likely is there COVID infection? That is what is the CORADS category. So CORADS 1 is when COVID infection is highly unlikely because the CT scan is absolutely normal. So remember, normal lung is not CORADS 0. Normal lung is CORADS 1. Remember, CORADS 2 is when it is unlikely because you see infectious patterns which are not typical of COVID. What is not seen in COVID? So suppose you see pleural effusion. So pleural effusion is never seen in COVID, right? Similarly, lobar consolidation is never seen in COVID, right? So you see pleural effusion or lobar consolidation, you say it cannot be COVID, that is CORADS 2. Equivocal, so you see a single central ground glass opacity. What is the pattern of ground glass opacity in COVID? It is usually multifocal peripheral ground glass. You see a single central, you say it is indeterminate equivocal. If you see few ground glass opacities, yes, it is probable, that is called CORADS 4. So few ground glass opacities. CORADS 5 is very typical or highly likely of COVID. That is when you see multiple peripheral multifocal, that is peripheral multifocal ground glass opacities. That is typical of COVID. We have just seen it, so that is called CORADS 5. And if you have the RT-PCR report which is present, then irrespective of lung finding, you say it is CORADS 6. So irrespective of CT findings, if RT-PCR report is positive, you say that it is CORADS 6. So this is what is COVID. Now see, there are some classic named signs that have been described in COVID. In COVID, the named sign which is described is reverse halo sign or atoll sign. So first we must know what is halo sign. What is halo sign? A central area of consolidation with a peripheral rim of ground glass opacity around it. This is the called as the halo sign. Halo sign has been described in invasive fungal pneumonia or invasive aspergillosis. Vaso-invasive aspergillosis. So invasive fungal pneumonia or aspergillosis, a central consolidation surrounded by a halo of ground glass is called halo sign. You see a reverse of that, it is called reverse halo sign or atoll sign in COVID infection. So you see a central area of ground glass opacity with a peripheral thick rim of consolidation around it. This is what is called as reverse halo sign or atoll sign seen in COVID. It is also seen in cryptogenic organizing pneumonia. So true regarding CORADS is what? CORADS 0 is normal lung? No. Normal lung is CORADS 1. Remember, CORADS 5 is typical of COVID is correct. Pleural thickening is typical of COVID. No. Pleural effusion, pleural thickening, lobar consolidation is not seen in COVID. COVID can present with lobar consolidation again? No. So what is the answer? The answer is going to be CORADS 5 is typical of COVID. Now remember, we are going to discuss few classical clinchers on chest X-ray that will point to a etiological diagnosis. I'll give you one example. We have seen pneumatocele, isn't it? Pneumatocele is seen in what pneumonia? So in consolidation, if you see pneumatocele, then it is seen in what pneumonia? We have seen it, it is staphylococcal pneumonia, correct? Similarly, if the examiner gives you a history of HIV positive patient with central ground glass opacities in a bat wing distribution, then in an HIV positive patient, what is the most common lung infection? Opportunistic infection? Yes, it is pneumocystis pneumonia or pneumocystis jirovecii, pneumocystis carinii pneumonia, central, angel wing like opacities. Monod sign, this is also called as a misnomer of air crescent sign. Monod sign or air crescent sign is a sign of a fungal ball or an aspergilloma, the crescent of air around, just above the fungal ball. Bulging fissure sign is a feature of Klebsiella pneumonia. Because of the excessive secretions, the lung expands, the fissure is going to bulge away from the involved lobe. It is a feature of Klebsiella pneumonia. And interstitial opacities are seen in an infective lung condition when it is atypical pneumonia. The most common cause of atypical pneumonia is Mycoplasma pneumonia. Yes. Friends, we've together completed all these final stride sessions. At this point, I want you to stop being afraid of what could go wrong and start being excited of what could go right. Well, you have prepared so hard for a very long period of time. There are going to be anxieties, there are going to be uncertainties, going ahead into this exam. But rather than choosing to focus on the negativities, if you try and focus on the positive and try to believe in yourself and give your best shot in this particular exam, I'm sure you could come out with flying colors. So let us hope that you get those 3, 4, 5 MCQs correct because of all these sessions that we have had together, right? And you get that dream score and your rank and your dream PG seat that you have been longing for. Let us get this dream seat together. All the very best.